Hey everyone, and welcome. If you're a pathology trainee, you know some cases just demand a whole other level of precision. Well, today we're diving into one of those, Merkel cell carcinoma. This isn't just about nailing the diagnosis, it's about building a complete, rock-solid report that actually guides patient care. So let's get into it. All right, so you've got your first Merkel cell carcinoma case on your desk. This is a rare and pretty aggressive skin cancer, and because of that, your report is absolutely critical. So what we're going to do is walk through the official College of American Pathologists, or CAP, protocol, step by step. Think of this as your playbook for perfect report. So here's our game plan. First, we'll talk about why a standardized protocol is so important for this cancer. Then we'll get into the nitty-gritty, sizing up the primary tumor, checking out the margins and lymph nodes, and then pulling it all together for the final staging. And to wrap up, I've got some pro tips straight from the guidelines that'll really make your report shine. Okay, first things first, the MCC reporting standard. You know, with an aggressive cancer like this one, consistency isn't just a nice little bonus. It's absolutely essential for making sure patients get the right treatment. And that's exactly where the CAP protocol comes in. Think of it as your ultimate checklist. Using its synoptic format forces us to systematically address every single core data point, from the tumor size all the way to the nodal status. This means oncologists, surgeons, radiologists, everyone gets the exact same high-quality info every single time. It's really the standard of care. All right, let's get to the heart of it, the primary tumor itself. This is where you're going to find some of the most powerful clues about a patient's prognosis. So there are 5 key features you've got to nail down in your report. Tumor size is a big one for staging. Mitotic rate gives you a sense of how fast the cells are dividing. Tumor thickness, and we'll talk more about this in a sec, is hugely important for prognosis. And then the growth pattern and whether or not there's lymphovascular invasion, that tells you a lot about how the tumor is behaving and its potential to spread. Now, check this out. This is a pro tip, straight from the protocol's notes. While the tumor's diameter is what we use for the official T staging, study after study shows that the tumor thickness is actually a better predictor of the patient's outcome. We're talking about measuring in millimeters from the granular layer of the epidermis all the way down to the deepest part of the tumor. It's a fantastic predictor of nodal metastases and survival. So even though it's technically optional on the checklist, you should absolutely be measuring and reporting it. This slide here perfectly shows another key feature, the growth pattern. On the left, you've got that nodular pattern. See how it's nice and well circumscribed? That's generally associated with a better prognosis. But on the right, you see the infiltrative pattern, with single cells just kind of snaking their way through the tissue. That's a much more aggressive look. And the rule is simple. If you see both patterns, you always call it infiltrative. Okay, so we've got the primary tumor all characterized. Now it's time to zoom out a bit and look at the specimen's edges and the regional lymph nodes. This is all about figuring out the risk of local recurrence and spread. Margin status is how you tell the surgeon if they got it all. But here's the thing, it's not enough to just write negative. The CAT protocol specifically requires you to state the exact distance, in millimeters, to the closest peripheral and deep margins. That level of precision is what helps clinicians decide if a patient needs another surgery or radiation. Okay, now for lymph nodes. And I really want you to pay attention to this quote because this is a huge deal in Merkel cell carcinoma. Metastases can be incredibly sneaky and super easy to miss on a standard H&E stain. Calling a node negative without doing your stains is a major, major pitfall. The CAP protocol strongly recommends against it, and for very good reason. So, what stains should you be using? Well, the protocol suggests a whole panel to make sure you don't miss anything. You've got your cytokeratin cocktails like AE1/AE3 or CAM 5.2, plus CK20, which gives you that classic dot-like pattern. Then you want to throw in some neuroendocrine markers like CD56, synaptophysin, or chromogranin. Using a panel like this is really the only way to confidently hunt down those tiny hidden micrometastases. Okay, we've gathered all our puzzle pieces. The tumor data, the margin status, the node status. Now it's time for the grand synthesis, putting it all together to figure out the final pathologic stage. For staging, we're using the AJCC 8th edition, and really, it all boils down to 2 main things, the size of the primary tumor and what's going on with the lymph nodes. One of the key updates in this edition is that it separates clinical staging, what the team knows before surgery, from pathologic staging, which is our job. So let's break down the PT categories. It's actually pretty straightforward. It's all based on that maximum tumor diameter. A PT1 is 2 centimeters or less. PT2 covers tumors between 2 and 5 centimeters. and PT3 is anything over 5 centimeters. Simple enough, right? And then PT4 is for any tumor, regardless of its size, that has invaded deep structures like bone or muscle. Now, nodal staging. This is a little more nuanced. PN0 is easy, no node mets. PN1 means there is metastasis. But then you have these unique categories for what's called in-transit metastases. These are little tumor deposits found in the skin between the main tumor and the lymph nodes. If you find those without any node mets, that's a PN2. If you find them with node mets, that's a PN3. In this table just pulls it all together beautifully. You can see how any patient with no positive nodes falls into stage I or II, depending on their T category. But the second you find a positive node, they jump to stage 3. Stage 2A is for those microscopic, hidden mets, while stage 2B is for nodes you could actually feel, or for those in-transit metastases we just talked about. And of course, stage 4 is for any tumor that's spread to distant sites. All right, we have covered all the required elements. Now for my favorite part, the pro tips. These are the details from the CAP protocol that aren't strictly required, but reporting them shows a deeper level of analysis and adds some serious clinical value. First up are tumor-infiltrating lymphocytes, or TILs. Basically, this is a snapshot of the patient's own immune cells launching an attack against the tumor. And while the research is still ongoing, a strong immune response is generally a good sign, so it's a really valuable detail to pass along to the clinical team. So how do we talk about them? Well, the protocol says we can borrow from the melanoma world. You have non-brisk, where the lymphocytes are just kind of sprinkled around. But what you're seeing in these pictures is brisk. This is an intense, widespread immune response. In image A, they're all along the base of the tumor, and in B, they're mixed in everywhere. Reporting TILs as either absent, non-brisk, or brisk adds a whole other layer of context to your report. And, finally, always keep your eyes peeled for a second malignancy in the same sample. MCC can sometimes hang out with squamous cell carcinoma. It's also really strongly linked to patients who are immunosuppressed, often from conditions like chronic lymphocytic leukemia, or CLL. And pointing out CLL isn't just an incidental finding. It's a major bad prognostic factor, probably because the patient's immune system is too compromised to fight the cancer effectively. When you get right down to it, a pathology report from Merkel cell carcinoma is so much more than a list of findings. It's a detailed story built on a standardized protocol. Every single data point, from tumor thickness to the presence of TILs, contributes to a narrative that directly shapes a patient's prognosis and their entire treatment plan. The care and precision you bring to that story makes all the difference.